Am I unmuted on this thing?
Yes, you are.
All right. Hello, everyone. Welcome to CPC. I am here, of course, to do my typical intro for our speaker, and a reminder to everyone that at the end of the talk, please hang around for an extra few minutes, and we'll be doing the chief resident announcement from the junior class. But that is after our main event. So I'm here to introduce Colin Kulick Soper. Colin did his undergraduate work at Georgetown University and went on to get his medical degree from the Rowan School of Osteopathic Medicine. There, he was on student council and president of the cardiology club, all of which I think was just foreshadowing for his residency performance, because here he's been on a number of similar leadership committees like steering committee, GMEC, and the ethics committee, and of course was one of the founding members of the narrative medicine group, and will be a chief resident with us next year, before going on, of course, to an esteemed career in cardiology. So please join me in welcoming Colin to the stage.
Thank you, everyone, for attending today. While I have a captive audience here, I also have a quick PSA that we do have a paint night event. Speaking of narrative medicine, it's tonight at 6 o'clock. We have extra canvases still up for grabs. Please come hang out and do a little painting with us and unwind. But to the main event, I am here to present a case of diffuse alveolar hemorrhage of unclear etiology. So jumping right in with this particular patient's presentation, we have a 62-year-old male with a past medical history of unilateral nephrectomy due to being a kidney donor, mitral valve prolapse, hyperlipidemia, and hypertension, who presents as a transfer to our ICU from an outside hospital for management and workup of diffuse alveolar hemorrhage of unclear etiology. So that's a whole lot up front. We have a lot of information coming into this case, but there's still a lot of questions that need to be answered. Some data from the outside hospital's emergency department course. He initially presented with acute dyspnea and hypoxia, and quickly progressed to requiring intubation and mechanical ventilation. In terms of past histories, his exposure history from a pulmonary perspective includes working as a pipe fitter and in a construction yard. He has 2 cats, and he has a pretty significant smoking history, but he quit over 10 years prior to presentation. Lab work was most notable for white cell count elevated to 20% with neutrophilic predominance, an NT-proBNP at 2400, and an RVP, a respiratory viral panel, was negative. They did some imaging there. The reports that we had told us that there were some bilateral multifocal ground glass opacities, but most significantly, there was a bronchoscopy, which showed a mild amount of blood and secretions in the main stem bronchi and lower lobe bronchus, and bronchoalveolar lavage of the right lower lobe bronchus showed progressive hemorrhagic return, which we'll go into in just a couple slides here. But that's really why we were able to say with some degree of confidence that this is likely a diffuse alveolar hemorrhage that the patient is presenting with. Like I said, he did progress to requiring intubation mechanical ventilation after failing high flow nasal cannulae, and was started on broad spectrum antibiotics for also presumed or possible pneumonia. On arrival to our MICU, he arrives intubated, sedated. His exam is most notable for, on cardiac exam, a 2+ hollow systolic murmur and mild pedal edema, but not particularly volume overloaded appearing. He's not on pressors. His abdominal exam shows a lot of bruising around the lower abdomen, and he has a faint abdominal scar on the left side from that history of being a kidney donor. The lab data that we got showed hemoglobin stable in the 9s as compared to the ED, and platelets within normal limits. The white count is stably elevated in the 20s. Labs are otherwise normal. Urinalysis is bland. He was initially managed with IV steroids, TXA nebs, and broad spectrum antibiotics were continued. He was diuresed with IV Lasix, and we ordered a slew of repeat imaging, including CT head, chest, abdomen, pelvis, and a transthoracic echo. So before we jump into working up a differential and getting further into this patient's case, I want to sidestep here and talk about what is diffuse alveolar hemorrhage, what is the differential for it, and how can we go into the case already saying that this is likely what we're dealing with. This is a very good succinct definition I found from a paper that described it as a distinct clinicopathological syndrome of pulmonary hemorrhage that originates from the pulmonary microcirculation. It often presents with hemoptysis, anemia, diffuse lung infiltrates, and acute respiratory failure, all of which is consistent with our patient's presentation. And the diagnosis is confirmed by the observation of accumulation of red blood cells, fibrin, or hemosiderin-laden macrophages in the alveolar space. So in this case, we were fortunate enough to have the bronchoalveolar lavage on presentation to our MICU that did show progressive blood in the lavage, and was able to tell us that this is likely what we're dealing with, because imaging alone is often insufficient to make that diagnosis. You might remember the buzzword hemosiderin-laden macrophages from your step 1 days. Basically what that means is when you bleed into the lungs, the lung macrophages try to clean up the mess, and they end up with a lot of hemosiderin, iron deposits in the lung. You can see on the screen here, there are a lot of these little darker areas. Here we go. It's almost like brown or black areas. And zooming in a little closer to the macrophages, these large black spots are basically the hemosiderin deposits from the macrophages trying to clean up that, that amount of red blood cells that has spilled into the alveolar space. So where does this come from? In one sense, this is a diagnosis in and of itself, but in another sense, it is just a symptom of something else that we need to figure out, what is triggering this? Why did this person have a disruption of their pulmonary microcirculation leading to this acute respiratory failure? Going into our etiologies of DAH by system, because in the ICU, we love to do our diagnoses and our plans by system. From a neurological perspective, there is an entity known as neurologic pulmonary edema that can precipitate this. It's not overwhelmingly common. Just be aware that it is a thing that you may come across. In terms of cardiac etiologies, the biggest thing is going to be CHF, or again, pulmonary edema, which again is going back to an entity that is disrupting the pulmonary microcirculation. Mitral valve disease can also precipitate increased pulmonary pressures that can lead to disruptions in the pulmonary microcirculation. Of course, there's lots of pulmonary etiologies for this, ARDS being a very important one. Pulmonary embolus, which can occur both due to an ischemic precipitant from disruption of the circulation, but also pulmonary hypertension and increased pulmonary pressures, again, leading to disruption of the pulmonary microcirculation. There's also a slew of infectious causes that are important to be aware of. Slightly different profile for immunocompromised versus immunocompetent patients. I did provide a list here that I found from a epidemiology infectious disease paper, but basically it's a very broad spectrum of different infectious diseases that can do it. These are certainly, it's not a comprehensive list, but these are ones to be on the lookout for, particularly Aspergillus, Mycoplasma, Legionella, and in immunocompetent patients, influenza A, which we've certainly been seeing a lot of this year, and a couple other less common things, at least in regards to the patient population we see here. In terms of hematologic issues, you can have all the three-letter acronyms, DIC, TTP, ITP, or pharmacological anticoagulation, basically anything that's going to make you more likely to bleed. For autoimmune or rheumatologic causes, yes. Think of an autoimmune or rheumatological disease, it probably has been associated with diffuse alveolar hemorrhage. And again, this is really going back to the disruption of that microcirculation. So think anything that's going to cause a vasculitis, like a medium or a small vessel, in particular vasculitis, is going to put you at higher risk for developing this alveolar hemorrhage. Other things that you should be aware of are lupus, rheumatoid arthritis, antiphospholipid syndrome, mixed connective tissue diseases, or cryoglobulinemias. This is a nice, more comprehensive list that I found. Some other ones I want to point out is like a good pastures or sort of like pulmonary renal syndromes are somewhat notorious for precipitating diffuse alveolar hemorrhage. But again, you should be on high alert for any sort of autoimmune or rheumatological condition if you're dealing with DAH. And then there's also the possibility that we did this, or it's due to some sort of ingestion. Amiodarone is a medication that can do it. Cytotoxic drugs or chemotherapeutic agents can certainly do it. Radiation therapy, nitrofurantoin, which is a fairly common drug. Bone marrow transplants can precipitate it. Lung transplant rejection can do it. And also inhalation or insufflation of toxins or chemicals, including illicit substances, can irritate the lungs and precipitate a DAH. Big picture, it really is associated most commonly, if you look at the breakdown, with vasculitides, although they're certainly not the majority of cases, they are a plurality of cases. But if you take that into account, like ANCA-associated vasculitides versus anti-GBM disease, like your pulmonary renal syndrome, SLE, APLA, you're looking at almost half the chart is somehow related to a rheumatologic cause. Infection, pulmonary hypertension take up another big piece of the pie, and then a couple other things in there as well that we've discussed. So how do you work this up? I already talked about this a little bit with the BAL. This is a nice flow chart that sort of walks through the different steps in diagnosing DAH if you have suspicion for it. Obviously, clinical history is a big part of it. And you can see another key part right at the top here is this bronchoalveolar lavage, that FOB and BAL. Also probably get some biopsies and culture to work up for infectious triggers. And the other limb of this down the middle is you want to be looking at your rheumatological signs and symptoms and get a thorough rheumatological serological workup. Also going back to the history, they have personal history, family history of these disorders. If they don't, they're going to get a nice thorough workup. You also want to worry about any potentially offending drugs or agents, and you want to do a thorough review of their cardiac and pulmonary disease history or risk factors as you're working it up. So with that in mind, what do we do to work up this patient's particular case? We started, like I said, with a good autoimmune and rheumatological workup. The notable findings, at least to start, were negative for the most part, a negative ANA and ANCA, negative anti-GBM, negative RF, C3, C4, and a bland UA, not showing any proteinuria or signs of inflammation. So it doesn't seem to be any underlying rheumatologic or like a pulmonary renal syndrome that we've been able to identify on first pass, although there still are some labs pending. Rho, anti-SMRNP, dsDNA, the anticardiolipin phospholipid labs, and Sjogren's antibodies were still pending at this point in the case. We did a good infectious workup, which was most notable for a E. fecalis on sputum culture, which was pan-susceptible and being appropriately covered by the antibiotics the patient presented with. Rest of the workup was negative, including a mycoplasma antibody, mercenaries, RVP, and urine Legionella. In terms of the cardiac workup, we got a transthoracic echo, which showed mild LV dilatation with a normal EF in the 60s, normal RV size and function, but there was a significant finding of posterior mitral leaflet prolapse with moderate to severe MR, moderate TR, and then a severely elevated PA systolic pressure at 70 millimeters mercury. Going into some of the findings here, for just to orient us, this is a peristernal long axis. So down at the bottom here, you have your, this is my pointer here. This is your left ventricle, left atrium, right ventricle. We're looking down from the sternum. This is roundabout where that mitral valve is. It's hard to see over all the color Doppler flow, but you can see there's a lot of turbulent flow. You see all this, what's called aliasing. You see blue, you see red, you see yellow, everything in between. That's indicating a lot of turbulent flow through and across this valve back into the atrium. And this is sort of in mid to end systole that we're getting this backflow. Taking a look at some of the images without the Doppler to get a better look at the valve. This is your anterior mitral valve leaflet, posterior mitral valve leaflet. You can see here that they're not exactly even. This is about where they should be. The anterior leaflet is more or less in the right place, but the posterior leaflet should basically be mirroring that. And you see that it's more prolapsed back into the atrium, and you have a little gap here because of that prolapse. And again, this is in like mid to late systole, and this valve should be closed. Here's another view of that. Again, this is apical 4, so here is your left ventricle, left atrium, and again, we're seeing a lot of turbulent flow across that valve in mid to late systole. This is Doppler. I know we don't look at these a lot on the primary internal medicine services, but basically there's this little circle here. What this graph is looking at the blood flow velocity at this point here where that little circle is. Upward deflection is blood flow going up towards the probe, and downward deflection is blood going away or down towards the atrium. And you can see here these big downward swoops. You have one of them outlined here. And looking at the area under the curve, it almost looks like there's more backwards flow than there is forward flow, which is not what you want at this point in the cardiac cycle. So this is a significant amount of mitral regurgitation that this is demonstrating. So because of this, we want to get a better look at those valves and the rest of the heart function. So we're going to get a transesophageal echo ordered and follow-up, which we will loop back to in a bit. But first, I want to make sure we discuss the CT chest that was ordered so that we can have our own images rather than just a report from the outside hospital. And for that, I'm going to hand off to our radiology colleagues to discuss the CT imaging.
Hey, can you hear me?
Yes.
Okay, cool. Let me try to share my screen. Also, did you want me to go over just the initial chest CT or sort of look at the ones from after as well?
Sure. If you don't mind going over the first one and then the subsequent ones as well.
Sure. All right.
Probably not the ones after the patient's transferred.
Like 7. Yeah.
Sorry, what was that? I couldn't hear that.
Sorry, just in reference to the ones after the patient was transferred, just the ones that were present in Pennsylvania.
Yeah, for sure. So just to sort of walk you guys through first what this would look like on an X-ray versus what it would look like on a CT. So in general, sort of similar to the clinical picture, the pattern of disease we see with alveolar hemorrhage is also what we call like non-specific, just because it can be seen with different disease processes. And essentially because the problem here is the alveoli themselves are getting filled with hemorrhage, it's going to look very similar to things that will, like similar things that will fill the alveoli with other stuff. So for example, edema or pus. That's why a lot of times you'll see sort of a report that says, this could represent hemorrhage, or this could represent edema, or this could represent infection, just because, something's filling the alveoli and it's going to look with what we call like an alveolar pattern of disease. So if you look at the chest X-ray, you see these sort of like patchy, sort of almost consolidative looking opacities bilaterally. They're diffuse. They seem to be affecting, some of the periphery is spared, which, is not a very specific sign, but it can be seen with alveolar hemorrhage. Sometimes you get more of a central predominance rather than a peripheral predominance. But if you just showed someone this radiograph in isolation, they would probably think, this could be edema, this could be infection, this could be hemorrhage. And it's sort of similar to what we'll see on the CT. So this was the CT that was taken after the patient presented. So first thing you'll notice, let me just window this correctly. Just to run you through some things that I look for when I'm looking at a CT. First thing here, we have the tracheostomy tube. You can see there's some secretions in the trachea here. There's also secretions down here and in the bronchi. So we sometimes comment on that just because that makes patients prone to aspiration. First thing you guys will see is we have these bilateral sort of small to moderate pleural, probably small pleural effusions. And then we have all these consolidative looking opacities. They're symmetric, they're diffuse, they're bilateral. They're basically affecting all of the lung. So we call them consolidative because you cannot see the vessels that are running through them. They basically, and I'll show you what the difference is between that and ground glass. Basically what this means is it kind of looks just like a white blob that you can't see through. And you can see something like this with, obviously with diffuse alveolar hemorrhage. In most cases, it tends to be central predominant and spare the periphery, but here you can see it pretty much affecting all of the lung. But you can also see something like this with really severe pneumonia. You can see something like this with really severe pulmonary edema. And this would, you know, my first impression when I opened this is this looks like something that you would see with ARDS, which is, you know, a similar thing where all the alveoli are filled with something. In that case, it would be sort of edema and fluid, whereas in this case, they would be blood. And really, the best way to differentiate between the two is with these other tests that you were mentioning, like bronchoalveolar, etc. So just to show you guys sort of the difference in severity and how these things progress or get better, on the follow-up chest CT, you see a lot of that like dense consolidation is gone. What you're left with is more like faint, what we call ground glass type opacities, where you sort of see this like a very light gray, but you can see the background lung and the vessels behind it. Basically, when you have gray ground glass, what that means is you might have like some filling of the alveoli. There's some stuff inside it, but it's not completely full and consolidated. And so you can sort of think of it as a continuum where, you know, ground glass might be subtotal filling of the alveoli, but once you're going into consolidation, you might have like really bad filling with collapse of the alveoli. And just something else I wanted to point out here, and this is sort of more of those like secretions that we like to pay attention to, where you can see like a lot of secretions here in the left main stem bronchus, but you know that's not that, you know, that might be just mucus. In cases where patients are coughing up blood, we like to look at that too, because there might be some blood intermixed with the secretions. But yeah, questions about that stuff?
Any questions from me? No, all good. Thank you.
Thank you. Yep.
All right. And so that again points us in this direction of diffuse alveolar hemorrhage. There's maybe also a component of ARDS. But given that and the TE or TTE findings, we got a TEE in follow-up. And I'm actually going to have Dr. Kohut has kindly offered to walk us through the transesophageal echo images for further discussion.
I think it's time this out. Let's see.
So while we're getting this loaded, I just wanted to mention that acute MR is something that, like in cardiology fellowship, we're like taught to recognize, but you almost never see it. It's one of these things you always have to think about in certain scenarios, but you rarely ever get to really take care of somebody in the midst of that. And the clinical scenario is somebody that comes in shocky, needs to be intubated, and then MICU team does what they do well, and the patient doesn't get better, right? It looks like ARDS, treated like ARDS, patient's not getting better. That's right away, you know, if there's any MR or any suggestion of mitral valve disease, I'm thinking, could this be really bad mitral regurg? And in this patient, I think it's important to note that the TE was done at like 5 p.m. on a Friday. So you guys all know we love doing TEEs, but we like doing them early in the day, not late in the day, but it's 4:30. I apologize, 4:30. 4:30. And thankfully the patient was intubated and we didn't need anesthesia because that becomes a lot harder to do. And so clinical scenario is this person gets transferred, diffuse alveolar hemorrhage. As Colin mentioned, one of the things that we have to think about mitral valve disease, this guy had a prolapsing leaflet. They don't typically rupture, but they can. They're myxomatous usually, and they can. The most common scenario that you guys will see acute MR is actually post-MI a week later, or a prosthesis that gets infected and goes bad. So this is a less common cause. So this is a transesophageal echo. The top of the probe is in the esophagus, right? So this first chamber is the left atria, the mitral valve, and the LV. This is the RV and the right atrium. Just a fun fact, transesophageal echo was pioneered in South Africa to look specifically at the mitral valve for mitral valve stenosis. But it really gets us lined up really well, as you guys can see. So we're looking here, and this is just transthoracic, looking good. And then here, this leaflet plane really should be straight across. So that outpouching there, that's the prolapse. And then here we see something worse than prolapse. We really see something just flailing across. And this echo density, you can see, is really flailing across the plane of the mitral valve. So this so far looks way more than prolapse and looks like a ruptured leaflet.
Are you ready for pathology? I can't see the screen.
Oh, I'm sorry. No, I'm actually just waiting for the echo pictures to load here.
Okay, sorry, I don't see anything. I still see the CT.
Yep. Patient. Yeah. The whole thing. No, nothing at all. Did we lose connection? Epic quit on us like it did yesterday afternoon. Unfortunately, I don't know that this is gonna. Can you guys get Singo directly or no? It's not on this. Not on this desktop. Yeah. Well, while we start to have it, maybe wait for this to load. Would you be able to just walk us through the report findings? And I know we don't have the images to accompany it, but yes. So I think the 2D, right, very important, right? The color flow is really impressive. Just a lot of backflow. The caveat is that the transthoracic that was done a couple days earlier was a good study, high quality study read by high quality echo, doc. But when you think acute MR, you got to think about it when you're looking at the study, because you're going to underestimate the severity of mitral regurgitation. Acute MR is different than chronic MR because that color gradient in chronic MR takes time to form. And usually when you see really like linear solid jets, it's straightforward that it's chronic MR getting worse. This is a tricky study. Even in transthoracic, there's just so much flow everywhere that I don't think you guys can appreciate the color scales. We use the color scales to look at different ranges of flow. And this is maxed out, and it still looks like a color mishmash, right? But you guys can get a sense that the probe is at the top, and a lot of flow is coming back towards that probe. All that yellow is coming back towards the probe. Caveat is all that blue is going away from the probe, right? So it's really even hard to begin to quantify. And then we get to some of these lower views here, and we see this outpouching that should have been the prolapsing leaflet that sort of would normally cup that regurgitant jet and then shift it over off to the side. Totally isn't doing it. So it was not only flailed, but also had a rupture through it, through the prolapsing leaflet.
You want to?
Yes. And let's see if we can just zoom in here. And so a lot of color. And as I sort of, what I'm doing now is I'm omning through, so I'm sort of ranging through with the probe, looking at different leaflets. And this, we slow that down. And this is sort of the tell. This is just like an astronomical amount of backflow. This is pretty much, there's nothing, the mitral valve is doing nothing at all. It's just flowing freely across the mitral valve plane. Usually acute MR doesn't have a murmur, and the flows on TE sometimes can be deceptively insignificant. And that was the case in this, and that's why, you know, a couple of days of the MICU team doing everything that they're doing, the patient's not getting better. Right away, when I heard like this guy had any mitral valve disease, I'm like, we got to look at that valve. And glad we did. And this shows that there's no longer a prolapsing leaflet. There's just a ruptured leaflet. It's the entire posterior leaflet that's ruptured. And part of the anterior leaflet looks completely dysfunctional also, probably because of the chordal rupture that happened. But this is just an astronomical amount of regurg, and everything else looks good. So won't bother you guys with the rest of the films. But this is a lot and can be very disorienting unless it's in the right clinical scenario. And this was exactly the right clinical scenario to just take this as just absolutely way more regurg than even the Doppler color flow can quantify for us.
Thank you. Yep. Appreciate your patience. All right. You got it. All right. Yeah. All right. So we have a whole bunch more information than when this patient first presented to us. So let's go through and sort of update our representation of what is going on with this patient and synthesize this new data that we've gotten. So we have the 62-year-old gentleman with past medical history of unilateral nephrectomy, mitral valve prolapse, hyperlipidemia, hypertension, who presents an acute hypoxic respiratory failure secondary to diffuse alveolar hemorrhage, with workup notable for negative immune serologies, eficalis positive respiratory cultures, and severe mitral valve prolapse with a flail mitral leaflet and severe pulmonary hypertension. So putting all of this together, our suspected etiology of their diffuse alveolar hemorrhage is, at this point, the mitral valve prolapse with flail posterior leaflet leading to a severe pulmonary hypertension. I'm going to, before we jump into some histopathology, I just want to briefly touch on what is mitral valve prolapse. This is a whole lecture unto itself, but very briefly, it's fairly common, affects 2 to 3% of the population, most of which it will probably not cause any major problems, certainly nothing to this degree. One of the ways it can be broadly classified is syndromic or secondary, and that would mean secondary to like a rheumatic fever or to some other sort of autoimmune pathology, or secondary to an ischemic event, versus non-syndromic or a primary mitral valve disease. There does seem to be a congenital component to this as well. It can lead to progressive insufficiency, and that backflow back into the pulmonary circuit can lead to significantly increased pulmonary pressures, particularly if it happens suddenly or worsens suddenly, as in the case of a rupture of a chordae tendineae or a flail leaflet that suddenly becomes totally insufficient. And all of a sudden you have a much higher burden of backflow into the pulmonary microcirculation. It's often associated with myxomatous degeneration of valve tissue, which can be either a primary or secondary etiology, or disruption of the chordae or the PAP muscles, such as in an ischemic event, or if someone has a really bad infective endocarditis that causes damage, leading to a rupture of not the valve itself, but the structures that help anchor that valve in place and make sure it's moving and coapting how it needs to. Myxomatous degeneration is a fancy word that basically just means this inner layer, this middle layer of the valve leaflet here that you see in tan is full of proteoglycans and a lot of connective tissue that helps the valve keeps its structure. And this is the region of the valve leaflet that ends up with degeneration in this myxomatous degeneration of the valve. So what happened to this patient? They were transferred to HUP for cardiothoracic surgery evaluation. The pending autoimmune and rheumatologic workup that was not yet back ultimately resulted negative with no evidence of underlying autoimmune disease. And the patient underwent a successful surgical repair of the mitral valve. And they also, in the course of the surgery, got a biopsy of the damaged valve, which our pathology colleagues are going to discuss with us.
All right. Doc, are you still on the call? We can see your slide. If you're speaking, you're still on.
Oh, sorry, I'm muted. Okay, sorry. Can you hear me now?
Yes, we can.
Okay, let me show. Sometimes it takes a second to focus. So, All right. All right. So this is the fragments of the mitral valve. I'm not sure if you can see. There are some. Bring the light up. Some areas that are a little bit kind of gray or blue. I'm not sure if you can see my arrow. These are the myxomatous areas of the valve here and here on top. Here's your inner lining, and here's the valve. And you can see there is some cells that are kind of cleared out a little bit. Focus again. So this is the myxomatous degeneration in this area. You can see here's some more normal part of the valve, but here you see this myxomatous change, or like kind of grayish light blue change throughout the valve. So instead of having all fibrous tissue, you have more of this myxomatous change here. You can see it more prominently, kind of light gray to blue. Again, here on the top, again, you see more myxomatous change. So there is no endocarditis that we see on this on these fragments. So it all just looks like myxomatous degeneration. Any questions or comments? We see this pretty frequently.
Any questions from anybody?
Does that ever get graded in some sort of way. So is there a spectrum of this disease that's seen on pathology, or it only gets to pathology when it's all the way at the end of the spectrum?
The question, if you couldn't hear it, is if there's any grading to the degree or extent of myxomatous degeneration, and whether you just tend to see valves that are kind of at the end of their life and have like pretty severe myxomatous degeneration, or if you ever see kind of a transition or gradual changes that are less common.
We never see normal valves unless we do autopsies on young people, and we almost never then take pieces of them, but we don't usually quantify it. We just say myxomatous degeneration and leave it to you, the clinical people, to decide how bad it was clinically. Yeah, I've never quantified it.
Thank you. All right, we'll turn it back over to Colin in that case. Thank you.
You're welcome.
All right, thank you again. So with that data in mind, the working diagnosis here is not just DAH secondary to a mitral valve prolapse and flail leaflet, but we can say that the flail leaflet is ultimately due to myxomatous degeneration that does not seem to be related to any sort of underlying autoimmune or rheumatologic pathology. Appears to be more likely a primary or a non-syndromal degeneration of that mitral valve. So with all this information in mind, I want to just highlight some learning points from this case that I want folks to take away. The first is that DAH is fundamentally a disruption of the pulmonary microcirculation, which can lead to severe or life-threatening acute respiratory failure. So anything that might disrupt microcirculation, whether that is infectious, rheumatological, hemodynamic, could potentially precipitate this. Bronchoalveolar lavage is a key diagnostic tool. CT can be very helpful, but it is non-specific at times, as we discussed, and is typically not sufficient to make the diagnosis without proving that that fluid that is in there is blood rather than something else. A thorough rheumatological and autoimmune workup is warranted in basically every case, because that is one of the major categories of precipitation of this disease. And then other common etiologies, again, include infectious triggers and cardiac or pulmonary pathologies that might lead to increased pulmonary pressures that ultimately lead to disruption of the microcirculation. And then to end off, I'd just like to thank the folks that helped me with this presentation, Dr. Catalano for providing me a fantastic CARDS quick care overlap case, Ajit for helping me prepare the slides, and all of our colleagues in radiology, cardiology, and pathology who helped present and go through this case with us. And here are my references. And with that, any other questions about this case?
Can I tell you a little bit more?
Absolutely.
So the part that I didn't like divulge, so the patient came from UB Hospital, which is in Delaware, and they were doing absolutely the best they could do for this guy. They were hitting him over the head with a gram of solid metal every single day, which is exactly what we all would do and continue to do when he got here. He actually got visited for pneumonia, in air quotes for anybody who's listening, and was put on antibiotics and steroids and was diuresed a little bit and went to the floor and did okay until he didn't. Okay, so what I think happened was that they diuresed him a little bit and they bought him a minute of time. And then he decompensated on the floor, he got intubated there, and there is no rheumatologist out there. Okay, so if you're presuming they have a rheumatologic emergency, I said, thank you very much for doing God's work, bring the patient here later. Okay, bring them here as fast as you can. Because they can't grease them, they can't do anything. So he gets here, and I just implored you to not, that angry heuristic will get you every single time. Because it's sold to me, PAH in a rheumatologic emergency. Okay, thanks. Okay, but I'm going to start again with 0. Because nothing that they were doing which should help him was helping. More of the outpatient story is that he had a cardiologist who was following his mitral valve collapse for a long time. He had an appointment to go there the following week, right? And the BB hospital echo showed moderate to severe, but they didn't have the outpatient echo to say, was it more severe than an echo before? So he gets here and we do all these things, and I call Dr. Colin, oh, so fired up, okay? So I'm like, I got one, because we will not be able to count how many times on one hand, and you will see this in our whole career. All right, that's why I was so excited. And he comes, and he, wait, what? 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 Can you tell me that again? And I said, but he's not on any vasopressors. He's hemodynamically stable. That's where like furrowed brow comes in. He goes running in at 4:30 with a T. Thank God. and I'm like, we figured it out. And why was he not on any vasopressors? Was because he was well compensated for a very long time. So over time, he was compensating for his mitral valve prolapse. Stop me at any point when I'm wrong. Okay. But then the thing blew, and that's when the wheels fell off. So it was kind of a very crazy story. And I was so thankful for the images at 4:30 in the afternoon, because when I called the thoracic surgeon, all stopped, no fuck, right? I gave him exactly what they needed to know, and he said, level 0, take him right now. Because you want, first he said, can you put an acapella in the guy first? Because he presumed the guy was in shock. And I said, no, he's not in shock. He doesn't need an acapella. You understand, a capella. An impella, an acapella is what I use, an impella. An impella, right. There's no ventilator, you don't need acapella. An impella is a device that supports your LV, right? Because you assume you can also an LV failure, right? The top fails, the bottom fails, and all goes back. So I said, no, he doesn't need that. He was like, I want him right now. Right now, before it hits. So he actually did quite well. He was trached, which is not a failure, just a stepping stone, because that way it was much easier for us to rehab. He did do rehab, and he's home now. I have stopped his chart the entire way through. And I called the physician back at PGY Hospital, who transferred him initially, because we don't do that enough, I think, and told her what happened. And she was very, very thankful. And she also said, I was trying to get them to do a TEE, and they were dragging their feet. But I'm glad he was with you, because we don't have CT surgery here. So no matter what, he was going to have to move around to get what he needed. So that was the end of the story. The thing that struck her and me is when I told her, I asked my residents what causes diffuse alveolar hemorrhage, and the first thing they said was cracked lung. Okay, and she burst out laughing and thought that was very funny. And I said, well, epidemiologically, that is what they see, right? And then they said, rheumatologic disease. So we were doing, and the cracked lung, you also treat with steroids. So we were doing all the things that he did quite well. But I couldn't pass this one up first.
Yeah, and honestly, that was the part that I kept saying, what? I couldn't believe that the patient wasn't shocked. And like Dr. Catalano says, the reason is because he lived with some degree of MR, and that actually helped him. That helped him survive, honestly. Because if he had just a little bit of prolapse and not much MR, and then all of a sudden had that rupture, he would have been dead probably within 48 hours. So the fact that he had this link, a decent amount of MR really allowed him to survive. Yeah.
Does anybody have any questions?
I think my big takeaway point, as always, the DAH is not an intrinsic diagnosis except for clinical symptoms. It's really due to something else. And we think about the rheumatologic conditions first. I actually love that this is an example of DAH that has nothing to do with rheumatology, because it also helps us remember to think more broadly about it and go systematically, as you did, and ended up at the right diagnosis. So,
Thank you, everyone, for your attention.